Case number 11, WG, 53-year-old male who actually had a cath because of worsening angina class 3 at an outside hospital, diabetic, hypertension, smoker. So he was found to have a totally occluded LAD. He did have disease of the ramus OM branch and RPDA disease. So essentially becomes diabetic, 3-vessel. So I think at the outside hospital, they did have heart team discussion, but patient the same preferred, does not want surgery. They did the ramus PCI, then were referred here for the PCI of, you can show the angiogram now, the PCI of totally occluded LAD, if you see here.
Show us the angio, yeah.
Yeah, so we have a dual injection, same. We have both, EF is near normal, 50%. And let me show you the dual injection. Yeah, if you can see here, we have, yeah, this is where we are. So if you see the RPDA, significant disease of the PDA, 95%, very soft lesion there.
Yeah.
But angiogram they had sent us looked like was a very long LAD CTO, but looks, since now he has been on aspirin Plavix since he had PCI of the OM. Yeah, look, looks not like a 10 to 15 millimeter CTO, no longer, but more important is after the distal vessel, there's a large diagonal that is coming off.
I also see that your retrograde approach, if you need be, you have an option there.
Yes.
Of course, you have this lesion in that you know it's a type A lesion, but I.
That's another thing. I think if we decide if we can't go antegrade and you have to do retrograde here, that we have to probably stent the PDA first before even we do anything.
Exactly.
Yeah. But same like we had discussed, we will go with the Fielder fine cross into the LAD.
Okay.
And then we have our Miracle and the Gaia wire ready. Did you make a curve here? Give me the curve. Yeah, yeah. So we'll try with the Fielder first. If it does not, then we go with the.
So you're going to try the same way you did with the other CTO, which was so fast. The wire was easy. And this one is not going to be that easy either, right? There's some calcium there.
Yeah.
A little bit, not as bad as the other one.
Yeah.
But let's
not as bad as the other one, but definitely some calcium there. You have the Gaia ready? Or MB?
MB is ready.
Is it the same view?
That's not the same view.
No, this is not. We moved.
Just go straight with a 6.
Yeah. Don't open if you need be. Go to this view, please.
Yeah. 439. LAO 439 cranial.
Yeah, that's
the trick here is that there's the diagonal. This might just keep favoring to go into the diag, so it's going to be interesting.
Ready?
Let's see what you do. Any comments from the panelists? Carlo DeMario, while she's fiddling with the Fielder. Is that a good approach? Antegrade first?
Yeah, of course, antegrade first. She probably saw a quite different situation before, but right now you have even the impression there is a little bit of staining at the level of the stump of the occlusion, so might be a sort of relatively acute lesion that was probably concomitant to the one that was treated on the left circumflex. Having said that, it's better never to underestimate, and of course the key issue here is to do properly with retrograde injection simultaneously while advancing the anterograde wire. I tend to prefer different type of microcatheters than the fine cross. Now you have big choice. You can go with Corsair Pro. You can go with thinner Caravel, which is particularly helpful also for retrograde approach. Turnpike LP again for retrograde approach. Regular Turnpike. You have again plenty of devices for various situations, and this made, I think, is one of the reasons why this morning Dr. Sharma could show its 90+% success rate, which is now commonplace not only in Japan but also in Europe and the US.
No, we are LAO 3 and 37. Okay.
Put it up. You need to put this up. That's what you need to do.
Okay, so tell us what's going on. So you, Dr. Carlo.
No, so I have the Fielder. Let's see if it does not go. We are ready to change for a Miracle wire.
Open 306.
It doesn't look as easy as the other one. You got through so fast on the other one.
Okay, get the miracle.
6, right?
Some die, yeah, some die anti-grade, so we know we are
This
in
is the
right
amazing
spot.
thing about these scores.
Miracle 6 guys.
Score, the first case is very complex, very difficult, and now you have a very simple.
And I think the question is the same. In the first 30 seconds, you get 20 seconds, you get an idea that this wire is doing any progress. If there's no progress, quickly change. So we'll go to the,
So your
This is what
next
you do.
wire is miracle,
miracle.
Miracle 6.
Who is moving?
and the tip you just
Flag.
basically just do the very tip
I'll hold
and
this
not
leg.
much of anything.
So which miracle?
Miracle 6 now we have.
Yeah, all right. So it's sort of intermediate,
Already intermediate.
weight miracle. I mean, majority of operators will probably go with these novel composite tips of the Gaia wires. Having said that, I mean, I'm sure that Dr. Kini will easily succeed, and I think that there are, sometimes a little bit of fashion in the way people adopt new technologies. My impression is that the Gaia has very low tip load and gives a little bit more of security not to dissect and not to go into the extraluminal space. Having said that, you have seen in her
like
capable
you're in
lens,
already.
everything looks simple.
Here she
What's
goes.
important is not only to have the feeling of the wire moving freely into the distal vessel, but also have a further confirmation with
And
the
you see she's
retrograde
already crossed the
injection.
lesion. Looks like it, right?
Yeah.
We crossed the lesion. You can confirm it with RCA. Injection.
Injection. Yep.
No, they don't open the Gaia.
Yeah, you're definitely in the distal vessel. Hopefully this one will be easier to...
So now I think actually the fine cross has gone further down. So give me a 300 run through. So you'll go exchange it to a 300 wire.
300 run through.
So if the fine cross has gone through, what you can do is use a 2.5 balloon to pre-dilate this.
So 300.
Yeah, take this out.
Yep.
Would you do any kind of a cutting balloon or...
I think just regular balloon should be okay. If
You think
we
so?
use a NC balloon and we know it opens the lesion, then we are done. If not, we may use a atherotomy, either likely angiosculp.
Maybe before deciding the type of balloon, I mean, there is a fairly large diagonal immediately distal to the occlusion. So personally, I think we should go with a
Wiring
very
both of them.
gentle dilatation, not
We
to
are
be
going to
sure
take a
to
two-
close
yeah.
the diagonal and then
That's what we
wire the diagonal or use a dual lumen catheter
So same, I'm
do
going
that.
to take out the RCA catheter and bring it down and leave it in the descending aorta. You don't need it anymore.
Well, I like the idea of even trying to see, to wire that diagonal, maybe even now. Would you think about dilating it now? I mean, wiring the diagonal or
Or
just...
I think we
maybe a-
dilate
Either way.
first.
Yeah, a 1.5 or a 2 balloon,
Yeah.
I think is relatively
What
safe.
balloon? What, 12? Okay, 15. So we have a 2.5-15 balloon. We'll do a dilation and we take a picture, then we wire the diag. I think it's very
Okay.
crucial here. You need to wire the diag because there is disease in the diag. Yeah, get us a fielder.
Insufflator. Guys.
Looks like it's going.
I think
Yeah?
right here, huh?
Yeah?
Okay, go up.
Going up here.
You might want to dilate a little more distally, too. Want to go more
Going up here,
distal?
4, 6.
Okay,
There
that's
it is.
okay.
8 atmospheres, 10.
Down. I'm going to go in a little bit. Okay, here. You don't want to go too
Going
distal and dilate the, at the level. The diag is just coming
8.
off at that area.
8, 10 atmospheres.
Very
Okay,
good.
down.
Dr.
Okay,
Mehta,
ready for
you'll
the
join
angiogram?
us, please, on the panel.
A little dissection.
Okay. Looks
definitely
like
will need
needs a lot of vasodilator therapy to the distal vessel. Okay, we'll wire the diag now,
Feel it?
Okay.
right?
How's the blood pressure? Everything else is
This is
good?
good. This is good.
So you can give a lot of
120.
vasodilation.
So even in your contralateral injection, you saw the LAD did not look robust. It was like diffusely diseased
Yeah.
all the way to the apex. So we're going to give some verapamil, nitro, and then we'll start wiring the DAG. Some vis-
Here you go. Wrap them up. Blood pressure about 110.
we have a blood pressure running about 120.
Nitro.
Okay.
So I gave verapamil half. Normally it's like 250 mics. So I'm giving a 200 mics of nitro, almost 150 of verapamil.
So with all these
nice
complex interventions, are you guys feeling comfortable putting these patients just on clopidogrel or an aspirin, or are you moving it up a notch with
No, I
ticagrelor
think,
or prasugrel?
Where we are, if you are doing a bifurcation, all the left main cases today will be on brilliant as long as we know that they can take it. Yeah. No
If they're not at a
contraindication
high
for
bleeding
bleeding.
risk, you are choosing a more potent agent,
Yes, definitely.
even though it's selective PCI.
Good. Another picture.
Let me just get rid of, hold on 1 second. Get rid of the water. Okay.
Hopefully you
good.
enroll some of these in the Twilight study.
More brisk flow, clearly. Love this.
Okay, looks like a diagonal total occlusion rather than vessel straightforward. So but we will try the fielder first. Otherwise, we may have to go with the CTO wire even for the diag.
I think maybe a little bit more cranial, no, view to help you with that.
You don't say we are epicranial.
You are.
Training 40.
Some dye there. That's where it is.
Yep. There.
I think it's a little bit higher up.
Whisper.
Yeah, around there.
I don't know.
That's
See,
it.
I think that's where it is. It's behaving like a total occlusion.
Oh, really?
No, dissection.
I'm worried, is there a dissection?
Our predilation probably caused some dissection.
Or plaque shift into it.
Pablo, bring the monitor to me. A little bit this way. Yeah, this side. It's way away. Okay, there.
You're right.
That's it. No? Oh.
No, no, no.
No, that's not it.
Maybe you can still see from the retrograde injection.
Diagonal.
Yeah, and before it was visible.
It was showing it before.
We took out the retrograde catheter. Okay, some antigrade.
I think it's a
I
little
think
higher.
we may need like a stiffer wire to get into here. Oh, now you see it better. Now you see it a little better. It's making it look like it's going, but you don't see it going there, some dye.
It's almost there. You got it.
There's a dissection right there, too. It's
Just look up north a little, and that's it.
Do you want to take a
So, yeah. Want to get the whisper wire?
Yeah, the whisper might help. So I think there's
Or some kind of a hydrophilic.
Or even that
Pilot?
the run through maybe going.
You want to bring the run through back? And just
Yeah.
run No, no, she has the run through right there.
Tip of the run through.
Yeah,
We're trying to see if I can put the fielder
You're putting
here
this
in the,
and use the run through for the side.
yeah. See if that will work.
Yeah, but she can take the loop out.
Oh, this is a long run through. Forget it. It's loop.
and also loop.
And a loop. See, the tip is gone.
Want to try a whisper or need
Some die.
Yeah.
Okay, get us a whisper open. It definitely opened up better.
For this type of wiring of side branches, I must say I love dual lumen catheters. I mean, we have only the Crusader in Europe, but here in the US, you have now just released the twin pass torque. That
No, we do have twin pass here, right? But was it here or it was called
No, see, the Ventures was the one that were recalled.
recalled? Ventures were recalled. But we do have the twin pass catheters, yeah. We'll try with the whisper. You want to try the twin pass? But then how? Yeah, difficult. No, this is okay. Now we are trying with the whisper wire. Get me another run through. 180 run through.
180 run through. A new 180 run through.
I think it's a little down further. Yeah.
I think it gets stuck in the lesion there.
Yeah.
That looks favorable.
I know.
Yeah.
Looks
Right
like
there,
that's
no.
where it is facing the diag, but would not go further in.
It's not dissection.
You think you need a miracle, and with the
No, I guess like
With
we
the
do-
backup, just like you do a
no, we could
CTO?
do like a previous case. There's
Yeah.
a lot of dissection here, stent across, and then we retrieve the diag.
I just feel like you don't have support once you get in it. If you had the little catheter, the micro catheter, then you can change wires and do
Sometimes.
things that you need to do. How to deal with them from Dr. Patel. Excellent, excellent talk. Go on and tell us what you did and how you got into that diag.
So one of, you see that we had created a lot of dissection in the LAD, and that probably was preventing my wires, which is fielder, and we tried whisper, getting into the diagonal. So one of the suggestion given, you see that he said use twin pass was not a bad choice, but instead we did something else. We knew that we are in the dissection plane and we're not going in, so we used this remember we had the fine cross.
Yeah.
I went back with the fine cross and then took a miracle 3 because
That's what I was
regular
saying to
fielder
you,
was
yeah.
not going. So just with the, you can see this is a fluoro save. With the miracle 3, with the fine cross there, we were able to get into the diag. We dilated it, and this is where we are. It's a
Excellent.
large diag, large LED, and what is the stenting technique you want us to show?
Well, I mean, I think, there's no question now you have to do a dual stent.
Yeah.
And it looks to me like another mini crush because,
But,
and I don't know, we have a panel here. Carlo, so she went back, she got this, Carlo and Gilles, either one of you. Gilles, first, then Carlo, what do you want to do here? There's
have
no
a six
provisional here, Gilles.
We have a 6 French guide.
Yeah, I agree. Mini crush technique would be possible. I'm a little worried by the dissection upstream. We need to cover it well. It could go higher, of course.
Yeah.
So we need to be careful with the left main.
Right, you see the dissection coming all the way up. I mean, your LAD stent is going to be quite long. So I think you're right there. Carlo? Any additional
Yeah.
remarks?
No, I fully agree. I think the crushing for that particular case is an excellent technique. I tend to use more often double kissing crush, but here I'm also afraid a bit of leaving the dissection too long and moving backwards into the main.
Yeah. This way we avoid having two stents at the same time.
I mean, I think you're going to need a pretty long stent, and not maybe even a little longer than that, no? Dr. Kini
No,
and the LAD?
this is not the stent. We have 6 French. I cannot go with 2 stent.
Oh, okay.
Because it will be 3 also. We'll have to do either a DK crush or, a serial T stenting.
Okay.
So I have a balloon in the LAD. We have a stent in the diag. So we will stent the diag.
And then remove it.
Okay.
Yeah. So show me some dye. Who has the dye?
I got it.
Okay.
There you go.
Some dye. Yeah. I think we are covering the ostium. Agree, everybody?
I think you have to come back a little more.
No. Here. See that.
Let's
Finish.
see. A
Good.
little- Now better. Good.
Okay. Go up.
Going up on the stand,
Yeah.
Yes.
6, 8, 10.
Go. 14, 16. Right?
Correct.
Down. Go up again. So now if we are going to use a DK crush technique, I have to take out the balloon, the wire, and then with the LED, I have to crush the stent.
Yeah.
Yeah, with the LED balloon. So looks good. This coming out, wire coming out. This is a fielder, right? Fielder has to come out.
Correct.
Good.
I'm ready to crush whenever you tell me.
Yeah. Now we have to crush that stent. Good.
Ready?
Go.
Going up.
What size is this
This is a
balloon? You have to
3/0
be careful you
balloon
don't
that we
dissect
had.
upward.
10, 12 atmospheres.
You know,
Good.
you haven't sealed the dissection proximally.
No, don't worry about that. We'll stent later. First, let's take care of this side branch. See now, when we crushed, I think the ostium of the stent got a
Yeah,
little
looks
collapsed.
small.
Okay, get us a new fielder, I guess. Right?
Yes.
This is gone. Okay, done. Coming out.
Okay. So the idea is now you're going to go back and recross that.
Yeah. See that crush? You see that?
Yeah, we can see the bunched up, crushed stent in the ostium. So let's see if you could cross it.
Exactly. And then get me a new fielder. Let's cross. And get me actually once you recross, your balloon that you need to dilate has to be an NC balloon. But we
That's
always
why I
have
like
trouble.
to use in
So we
CTOs.
probably-
I like to use a larger. I like to use a 7 French guide always.
yeah,
you know,
yeah,
with CTOs.
Exactly. We would have been done with mini crush and going
You
home.
go home now. Yeah.
Yeah. Now we have multiple steps here.
Okay, but that's good. It's a good example that you teach us.
And get me a 2012 balloon, right? 2012. So we cross, open it. Oh, only problem will be the same. This dissection may prevent us from crossing in the diagonal.
You got it.
You think a 2-0 will go?
I think it will. 2-0 will go.
Get
I
us
mean,
a
1.5 is nicer,
1.25
but
ready. You have to do a kissing also, right?
yep,
We have to still deploy the main vessel.
you got to follow the steps.
Ay.
It's on your app, isn't it?
I know.
In case
I
we
would now
forget.
want to do the DK crush.
Okay.
But it avoided the issue of two.
So tell us the steps. Go through them all. So now you will
Okay, now
dilate
I
that.
need LED balloon.
LED balloon or LED?
Good. So good.
See how nice it went?
And this
And
will
now
be
you'll
this will
kiss.
be the first kiss.
Let's bring the other balloon
You have the
too.
3020, the same balloon.
2.0? Why not 2.5?
Okay, yeah. Give me. You have the 2.5, right? Yeah, get us a 2.5 to the LED. Agree. What's the stent you want in the LED? We'll take a long stent like you guys
You
mentioned.
need very long, I
You want
think.
a
Well,
38?
guys, what do you think?
No, we'll take a caudal picture to see how proximal.
I think you need to take a little better picture for me
Okay.
to see where that. I don't think this is a good view. I think maybe an iliocaudal something to show us where it, or an ariocaudal something to see where that proximal dissection is coming into to the left main. Some other caudal view.
Okay, good. We are going with the LED balloon. So we'll dilate the side branch, then we do the kissing, then we get the LED stent in. Then we have to recross and kiss again. Okay, good?
Yeah.
Okay, I'm going to the diag, going up, go. Go.
And going up. to
Still
the main
doesn't
vessel.
look very
We want to make
nicely
sure that the
dilated,
ostium
you
is
know?
nicely open.
What size is that? 2.5?
Yeah, we went with a 2.5. You told us go 2.5, we took 2.5.
Yeah. What size
I mean,
is in the?
ideally should be 1-to-1 in the LED, should
Yeah.
have been a 3.0. And then the diag, we have a 2.0, but it should be 2.5 NC
2.5
below.
for sure. I just
Good.
don't like
This
that
is good.
at all.
Done. Okay, slipped. He wants to go there? You want to go there or you want to watch the steps? Now see that we have nicely opened the diag, that crush that we did. Ready?
Yeah.
I'm ready.
So what did the decay crush study definitely showed that if you do this crush and then kiss, and kiss, that you're recrossing after you place the first, stent of the main vessel, recrossing and as well as kissing is higher rate.
I just want to see the extent of that
Okay, okay.
dissection
We will.
proximally.
I'll give you a caudal picture.
Is it, hopefully it's not in the left main.
Want to stent?
Not to worry. Now we stent.
3.0.
38 or 32?
32.
Here.
We'll see.
Okay, caudal.
Here we are. Caudal.
It's too big, no?
You need to get those wires more distally.
Ready?
I'm ready.
The diag wire.
Diag wire is a little backward. That's
Yeah.
okay. It has to come out anyway.
I know, but
Looks okay,
Oh,
no?
okay, good.
Yeah.
so
we
you
will
see,
put
I
a
just wanted to
3.0
make sure.
we'll
You
put
see
a-
how much
yeah.
better you see that.
We'll put a 3.038, then we recross and kiss.